Good evening and namaste to all. Welcome to another pre-course online discussion. Today my topic is clinical examination of knee. Few tests you must do. I am myself Dr. Sailendra Kumar Dual Shrestha from Nepal Armed Police Force Hospital and my moderators are Dr. Rajiv Rajmanandar and Dr. Naveen Khan. Every examination is as good as history taking. One can arrive at the working diagnosis for a knee pathology based on the history alone. The clinical examination can then be focused to confirm or supplement. CT scan and MRI scan in clinical practice has stolen the central role of clinical examination. The efficacy of a correct clinical examination need not to be forgotten. Same general rule applies for clinical examination of knee. All the basic steps of inspection, palpation, range of motion, and special test for stability. On inspection, we have to look for deformity, swelling, previous scar or scar due to trauma, muscle atrophy. On palpation, we have to feel the joint line tenderness, tenderness over soft tissue structures. We have to palpate the point of maximal tenderness, and we also have to feel for the neurovascular status of the limb. Assessment of knee range of motion is very important to determine if there is any mechanical block, lack of motion due to arthritis or previous surgery, or increase due to ligament laxity. First active and then passive range of motion should be elicited. The normal flexion and extension ranges from 10 degree of extension to 100 degree of flexion. Rotation varies with flexion. In full extension, there is minimal rotation. At 90-degree flexion, there is 45 degree of external rotation and 30 degree of internal rotation. In full extension, there is 0 degree of abduction and adduction, while at 30 degree of flexion, there is a few degree of passive abduction and adduction possible. Coming to a special test, Lachman test. It is the most sensitive test for ACL injury. Knee is kept on 20 to 30 degree of flexion. One hand supports the thigh just above the knee and the other grasps the upper end of tibia. The grading of a Lachman test depends upon the extent of anterior glide. Grade 1 is soft infield appreciation, that is 0 to 5 mm of displacement. Grade 2 is visible anterior displacement of tibia 5 to 10 mm of displacement. Grade 3 is gross anterior tibial translation, that is more than 10 mm of displacement. Endpoint should be graded as hard or soft. Endpoint is said to be hard when the ACL abruptly halts the forward motion of the tibia on the femur, and endpoint is soft when there is no ACL and restraints are more elastic secondary stabilizers. In Trilat's modification of the test, the thumb is placed on the tibial tubercle so as to get visual evidence of the translation. In the PCL tear, it may give false Lachman due to posterior subluxation. Pivot shift test. This is a dynamic test that shows the subluxation that occurs when the ACL is non-functional. It is performed by extending an ACL deficient knee, which results in small amount of anterior translation of the tibia in relation to the femur. During flexion, the translation reduces, resulting in shifting or pivoting of the tibia into its proper alignment on the femur. The pivot shift is performed with the leg extended, the foot in internal rotation, and the valgus stress is applied to the tibia. In early flexion, the anterolateral quadrant of the tibia is forced to sublux by internal rotation and valgus. This reduces with a clunk by posterior pull of the iliotibial tract with further flexion up to 20 to 40 degrees. This is a classic paper on grading of pivot shift test by Jacob et al. They have graded into grade 1, grade 2 and grade 3. I think everybody should go through this paper. In grade 1, the pivot shift test is positive only in medial rotation. In grade 2, the test is positive in medial and neutral rotation and negative in lateral rotation. In grade 3, it is pronounced in neutral rotation, even more obvious in lateral rotation, and is moderate on medial rotation. Anterior droid test. It is more of a historical test rather than an actual clinical test. In this test, the patient is in supine position with hip flexed at 45 degree and knee at 90 degree. The examiner sits on the dorsum of the foot and pulls the tibia forward. If the tibia shifts anteriorly more than 6 to 8 mm, it indicates ACL rupture. According to these two classic papers, Lachman test, antidroid test, and pivot shift test are clinically proved tests for ACL deficient knee, and among these, Lachman is more sensitive and specific test for ACL injury. This is another paper on accuracy of Lachman and anterior droid test for anterior cruciate ligament injury, and they have concluded that the diagnosis of ACL injury and the decision to reconstruction of ACL could be reliably made with regards to the anterior drawer and Lachman test result. The tests did not have privilege to each other. The test accuracy increased considerably under anesthesia, especially in women. This is a paper on accuracy of three diagnostic tests for anterior cruciate ligament tears. In this study, they have concluded that during the physical examination, a positive result for the pivot shift test is the best for ruling in an ACL rupture, whereas negative results to the Lachman test is best for ruling out an ACL rupture. They have also concluded that the Lachman test is better overall test at both ruling in and ruling out ACL rupture, and the anterior droid test appears to be inconclusive for drawing strong conclusion either way. Posterior droid test. It is the most accurate maneuver for diagnosing PCL injury. It is done with the knee at 90 degree of flexion. A posteriorly directed force is applied to the proximal tibia and posterior tibial translation is quantified. The medial tibial plateau of a normal knee at rest is approximately 1 cm anterior to the middle femoral condyle. Posterior sag sign. On the top left picture, one can appreciate the dropping back of the tibia on the injured side compared to the normal on picture on right. This test can also be done with patient in supine with hips and knees flexed to 90 degree. Examiner supports ankle and observes for the posterior shift of the tibia as compared to the uninvolved knee. In the normal knee, the tibial plateau is located approximately 1 cm anterior to the femoral condyle. In a patient with a tear, the prominence is diminished and there may be subluxation of the tibial plateau posterior to the femoral condyles in severe PCL injury. Posterolateral droid test. This test is conducted by applying posterolateral force on the proximal tibia with the hip flexed to 45 degree, the knee flexed to 90 degree and the tibial rotated 15 degree externally in supine position. When the tibial condyle show more external rotation than the lateral femoral condyle, it indicates the presence of posterolateral injury. Dial test. It is commonly performed with the patient in both supine and prone position. For the dial test, at 30 degree of knee flexion, one can perform it either supine or prone. When performed in supine position, the knee is placed over the side of examining table and an external rotation force is applied across knee through the foot and ankle with knee flexed at 30 degree. One will visualize the motion of the tibial tubercle to determine if there is an increase of posterolateral rotation of 10 to 15 degree compared to the contralateral side. When the dial test is performed prone, one assesses for the side-to-side differences in rotation of the feet. The dial test at 90 degree is also performed to determine the amount of rotation of the tibia which occurs on the femur. A positive dial test at 90 degree usually indicates a combined posterolateral corner and cruciate ligament injury. Coming for collateral, we do various stress tests for lateral collateral. We appreciate the lateral opening in varus stress test. It is done by applying varus stress with knee at 0 degree and bent at 30 degree. The 0 degree test is for lateral collateral as well as the cruciate ligaments, while 30 degree only tests the lateral collateral. If there is only pain, it indicates mild sprain. If there is pain and laxity, it indicates moderate sprain. If there is no fixed endpoint, it is suggestive of complete lateral collateral rupture. Valgus stress test, we look for medial opening. It is done by applying valgus stress with the knee at 0 degree and bent at 30 degree. 0 degree it tests for medial collateral as well as the cruciate ligaments, while 30 degree it is only for the medial collateral. If there is only pain, it is mild sprain. If there is pain and laxity, it is moderate sprain. If there is no fixed endpoint, it suggests of complete rupture. Posterior drawer test, it is the most accurate maneuver for diagnosing PCL injury. It is done with the knee at 90 degree of flexion. A posteriorly directed force is applied to the proximal tibia and posterior tibial translation is quantified. The medial tibial plateau of a normal knee at rest is approximately 1 cm anterior to the middle femoral condyle. Thessaly test. The, in this test, the patient stands flat-footed on one leg. The examiner holds his or her hands. This test is most sensitive and specific at 20 degree of flexion. The patient is asked to internal rotate the body or external rotate the body. The pain at medial or lateral joint line or locking is suggestive of meniscal tear. According to these two classic papers, Lachman test, anterior test, and pivot shift test are clinically proved tests for ACL deficient knee, and among these, Lachman is more sensitive and specific test for ACL. There are also other tests for detection of meniscal injury, but joint line tenderness, McMurray test, and Thessaly test are more sensitive and specific than any other test for detection of meniscus injury. On palpation, we have to feel the joint line tenderness, tenderness over soft tissue structures. We have to palpate the point of maximal tenderness, and we also have to feel for the neurovascular status of the limb. There are 32 points of tenderness elicitation, 11 major tests, 23 minor tests, and many other lesser known tests. Surgeons should develop heuristic abilities soon to elicit only those tests beneficial in that particular patient. We should keep it simple and create our own sequence for examination. Always examine the both knees. And lastly, always try to diagnose by clinical examination with complementary aid from MRI. Thank you everyone. Sorry for the late upload of my presentation. I would like all my seniors and colleagues to actively participate on discussion to be held on 18th of June 2018 at 8 to 9 o'clock tomorrow. Thank you very much.